السلام عليكم طلاب. محاضرتنا اليوم هي تكملة لمحاضرة النون ستيرويدال انتي انفلاماتوري دراجز. راح ناخذ selective COX-2 drugs، وموضوع ثاني أيضا drugs used in gout. The selective COX-2 inhibitors are a new group of drugs that provide potent anti-inflammatory activity without causing significant GI toxicity. طبعا هذا معروف لأنه تشتغل على ال COX-2 اللي هو مسؤول على ال production of prostaglandin that are inducible and prevent the inhibition of to some degree COX-1, which is responsible for production of prostaglandins that are constitutive or needed for the body functions. Celecoxib, the first selective COX-2 inhibitors to be marketed, was soon followed by the release of rofecoxib and valdecoxib. The later two drugs were withdrawn from the market because of the relative increase of the conferred cardiovascular events شرحناه بالمحاضرة اللي فاتت مثل الهارت اتاك and stroke، لذلك سحبوها من السوق. Uricosuric, another drug with a claimed stronger analgesic efficacy than celecoxib, موجود second drug but still not approved by the FDA, but it may have stronger analgesic efficacy. It's approved currently in 80 countries worldwide, but not in the US because it is not approved yet by the Food and Drug Administration, FDA. Together, these agents are known as COXIBs. Celecoxib is more selective for inhibition of COX-2 than COX-1, about 10 to 20 times. It's approved for the treatment of rheumatoid arthritis, osteoarthritis, and acute mild to moderate pain. Celecoxib has similar efficacy to non-steroidal anti-inflammatory drugs in the treatment of pain. طبعا بس هو شيء يتجنب من يشتغل اكثر على الكوكس 2 راح يجنبنا الادفيرس جي اي او تقل عندنا الادفيرس جي اي effect. Recent studies show that non-steroidal anti-inflammatory drugs including celecoxib can delay or slow the progress of Alzheimer's disease. In addition, celecoxib is found to be more effective than non-selective COX inhibitors in protecting against colon carcinogenesis. Pharmacokinetics, celecoxib is readily absorbed, reaching a peak concentration in about 3 hours. It is extensively metabolized in the liver by cytochrome B450, CYP2C9, and is excreted in the feces and urine. The half-life is about 12 hours, and the drug may be dosed once or twice daily. Adverse effects of celecoxib: headache, dyspepsia, diarrhea, and abdominal pain are the most common adverse effects. Celecoxib, as we said, is associated with less GI bleeding and dyspepsia than other non-steroidal anti-inflammatory drugs. However, this benefit is lost when aspirin is added to celecoxib therapy. Patients who are at high risk of ulcers and require aspirin for cardiovascular prevention should avoid the use of celecoxib. Well, it is contraindicated in patients who are allergic to sulfonamides. ليش؟ لأنه because celecoxib is also a sulfa non-steroidal anti-inflammatory drug. يعني يحتوي على السلفا group in its structure, chemical structure. As with other non-steroidal anti-inflammatory drugs, kidney toxicity and cardiovascular events may occur. Celecoxib should be avoided in patients with chronic renal insufficiency, severe heart disease, volume depletion, and/or hepatic failure. Inhibitors of CYP2C9, such as fluconazole, fluvastatin, and zaverlocast, must increase serum levels of celecoxib as drug interactions. Now, choice of non-steroidal anti-inflammatory drugs. All non-steroidal anti-inflammatory drugs, including aspirin, are about equally efficacious, with few exceptions. عندنا شغلتين. التولميتين ما يستخدم بالgout، والaspirin less effective in ankylosing spondylitis, may be related to its because of different potency required for treating the disease. For patients with renal insufficiency أحسن شيء عندنا هي الساليسيليت اللي هي non acylated، يعني عدا الأسبرين ساليسيليت البقية مثل الساليسيليت، صوديوم ساليسيليت، salicyl salicylate, which are effective anti-inflammatory drugs, but they do not inhibit platelet aggregation. Diclofenac and Selendac are associated with more liver function test abnormalities than other non-steroidal anti-inflammatory drugs. They relatively expensive selective COX-2 inhibitor celecoxib is probably safest for patients with high risk for GI bleeding, but may have a higher risk for cardiovascular toxicity اللي شرحنا عنها. The choice of a non-steroidal anti-inflammatory drug thus require the balance between the efficacy, cost-effectiveness, safety, and numerous personal factors. Example, other drug being used with the non-steroidal anti-inflammatory drugs, or concurrent illnesses, or compliance of the patient. So that there is no best non-steroidal anti-inflammatory drug for all patients. There may, however, be one or two best non-steroidal anti-inflammatory drugs for a specific person. هذا المخطط يوضح لنا ال therapeutic advantages and disadvantages of selected non-steroidal anti-inflammatory drugs. يعني خواص الأدوية اللي قد تكون مفيدة أو مو مفيدة، مضرة. For advantages, aspirin is low cost, long history of safety. Diflunisal less GI irritation than aspirin. Selendac long half-life permits daily or twice daily dosing. عندنا مجموعة البروبيونيك acids عندها low toxicity and better acceptance in some patients. Naproxen is considered by some experts as one of the safest non-steroidal anti-inflammatory drugs. الأوكسيكامز أيضا عندها long half-life وبالإمكان نعطيها single time daily. السيليكوكسib يسوي less GI irritation than aspirin or other non-steroidal anti-inflammatory drugs. بالنسبة ل disadvantages عندنا common upper GI disturbances with aspirin and indomethacin. الديفلونيسال ما عنده antibiotic effect. الانdomethacin مثل ما قلنا very potent, should be used only after less toxic agents have proven ineffective. يعني مو first line drug إلا إذا بقية النون-steroidal anti-inflammatory drugs ما تشتغل أو يعني have no intended effect. CNS disturbances are also common with indomethacin. Celecoxib, as a benefit causing low or less GI irritation, it also increasing the risk for myocardial infarctions and strokes. Drugs used in gout. Gout is a metabolic disorder characterized by high levels of uric acid in the blood, hyperuricemia, causing recurrent episodes of acute arthritis due to deposition of monosodium urate in joints and cartilage. Monosodium urate is the end product of purine metabolism in humans and is poorly soluble substance. فمن يزيد اليوريك اسيد بالبلد طبعا راح يتجمع بالجوينتس ويسبب لنا قد يسبب attacks of gout. Uric acid renal calculi, tophi, uric acid masses in the joints, and interstitial nephritis may also occur. Hyperuricemia does not always lead to gout, but gout is always preceded by hyperuricemia. The prevalence of gout varies between populations, but is approximately 1 to 2% with a greater than 5 to 1 male predominance. يعني male to female predominance. It is the most common inflammatory arthritis in men and in older women. The risk of developing gout increases with age and with serum uric acid levels. This figure showed the inflammation of the joints caused by gout. This is the healthy joint, while here there is inflammation of the joint with the deposition of uric acid crystals. And this is the tophus. Pathophysiology. About 1/3 of the body uric acid pool is derived from the dietary source and 2/3 from endogenous purine metabolism. The concentration of uric acid in the body or in body fluids depends on the balance between endogenous synthesis and elimination by the kidneys, 2/3, and the gut, 1/3. Purine nucleotide synthesis and degradation are regulated by a network of enzyme pathways. Xanthine oxidase catalyzes the end conversion of hypoxanthine to xanthine and then xanthine to uric acid. The causes of hyperuricemia are shown in the box in the next slide. In over 90% of patients, the main abnormality is reduced uric acid excretion by the renal tubules, which impairs the body ability to respond to a purine load. In many cases, it is genetically determined. The deposition of urate crystals initiate an inflammatory process. Urate crystals are initially phagocytosed by synoviocytes اللي موجودة بالsynovium lining the joints, which react by releasing eicosanoids, lysosomal enzymes, and interleukin-1. The above mediators attract leukocytes to the sites that lead to augmentation of the inflammatory process in the joint. Later on, phagocytes appear, which ingest the urate crystals and release more inflammatory mediators. The process generates oxygen metabolites, which damage tissues causing rupture of lysosome, followed by death of phagocytes and release of hydrolytic enzymes that evoke the inflammatory process. هسه راح نشوف شلون يصير الباثوفيزيولوجي of gout. Causes of hyperuricemia and gout: diminished renal excretion اللي مسؤول عن 90% من الجاوت، يا اما or increased intake، طبعا كلها باسبابها، زين، or overproduction of uric acid. ثلاثتهم يؤدون إلى زيادة الuric acid in the blood and its deposition in the joints or renal tubules. This figure showed the pathophysiology of gout. Here, first, synoviocytes ingest urate crystals and release eicosanoids, interleukin-1. This will attract the leukocytes, such as polymorphonuclear cells, which release inflammatory mediators that augment the inflammatory process. Later on, mononuclear phagocytes, which also ingest the urate crystals, will release, this process releases more oxygen metabolites, toxic metabolites, which will lead to rupture of the phagocytes and release of hydrolytic enzymes, which augment the inflammatory process. Drugs used for treatment of gout. Most therapeutic strategies for gout involve lowering the uric acid levels below the saturation point, which is less than 6 milligram per deciliter. saturation point. saturation point هي 6 ملغ per deciliter. الغرض من العلاج هو انه نقلل level of uric acid below 6 milligram per deciliter, thus preventing the deposition of urate crystals. This can be achieved by, first, interfering with uric acid synthesis by xanthine oxidase inhibitors, which are allopurinol and fepoxostat. Second, increasing uric acid excretion with uricosuric agents, such as propanacid and sulfampirazone. Third, inhibiting leukocyte entry to the affected joint with colchicine. Fourth, as an anti-inflammatory effect. Fourth, by the general anti-inflammatory and analgesic effect of non-steroidal anti-inflammatory drugs and occasionally glucocorticoids. هذا المخطط يوضح لنا الميتابوليزم of urinonucleotides and the drugs acting on each site of metabolism and excretion. First, urinonucleotides are converted into hypoxanthine, which is converted into xanthine and then uric acid. Xanthine oxidase enzyme is inhibited by drugs which decrease production of uric acid, which include allopurinol and fepoxostat. Uric acid is then excreted through urinary tract or alimentary or deposited in tissues. For urinary excretion, uricosuric drugs act here. When there is excess of uric acid, uricosuric drugs will increase the excretion of uric acid. With tissue deposition, there will be inflammatory process مثل ما شرحنا بالpathophysiology, and here anti-inflammatory drugs such as non-steroidal anti-inflammatory drugs, corticosteroids, and also colchicine act here at this step. So gout is a chronic disease with acute attacks. So we have treatment of acute gout and the treatment of chronic gout. Treatment of acute gouty attacks can result from a number of conditions, including excessive alcohol consumption, a diet rich in purines, or kidney disease. The drugs used here are non-steroidal anti-inflammatory drugs, corticosteroids, and colchicine. As non-steroidal anti-inflammatory drug, indomethacin is considered the classic non-steroidal anti-inflammatory drug of choice. Although all non-steroidal anti-inflammatory drugs are likely to be effective in decreasing pain and inflammation, well, low dose of aspirin is contraindicated because it competes with uric acid for the organic acid secretion mechanism in the proximal tubule of the kidney. يعني كل النانستيرويدال نقدر نستخدمها، واهم واحد بيهم هو الاندوميثاسين بس عدا low dose of aspirin is contraindicated. Intra-articular administration of glucocorticoids, especially if one or two joints are affected, is also appropriate in acute attack. الكولتشيسين هسه راح نحكي بالتفصيل ورا لاحقا. Patients are candidates for prophylactic therapy, example with arapirinol, if they have had more than 2 attacks per year, or the first attack is severe or complicated with kidney stones or tophi, and serum urate is greater than 10 milligram per deciliter, or urinary urate excretion exceed 800 milligram per 24 hours. Treatment of chronic gout. Chronic gout can be caused by, first, a genetic defect, such as one resulting in an increase in the rate of purine synthesis, or renal insufficiency, or excessive production of uric acid, example with cancer chemotherapy. Urate-lowering therapy for chronic gout aims to reduce the frequency of attacks and complications of gout. Treatment strategies for chronic gout including the use of xanthine oxidase inhibitors to reduce the synthesis of uric acid, or use of uricosuric drugs to increase its excretion. Xanthine oxidase inhibitors are first-line urate-lowering agents, especially in patients with excessive uric acid synthesis or with previous histories of uric acid stones or with renal insufficiency, while uricosuric agents can be used for patients with gout associated with reduced urinary excretion of uric acid. يعني الالوبيرينول الفيبوكساستات اكثر استخداما بالبروفلاكتيك تريتمنت لانه الانديكيشن مالتها اكثر. Note initiation of urate lowering therapy بهذين الدراجز اللي الفوق can precipitate an acute gout attack due to rapid changes in serum urate concentration. لذلك, at the beginning or initiation of treatment with urate lowering therapy, we must give either low dose of colchicine or non-steroidal anti-inflammatory drugs at the beginning, at least for 6 months, until steady serum uric acid is normalized or decreased to less than 6 mg per deciliter. ليش؟ حتى نتجنب حصول acute gouty attacks during the initiation of treatment with urate lowering therapy. Colchicine. Colchicine is a plant alkaloid. Has been used for treatment of acute gouty attacks as well as chronic gout. Colchicine has a suppressive and prophylactic effect that reduces the frequency of acute attacks and relieves pain. Well, mechanism of action: colchicine binds to tubulin and prevents tubulin polymerization and macrotubule formation. هذا cellular mechanism of action. This disrupts cellular functions such as the mobility of neutrophils and decreasing their migration into the inflamed joint المهمة، وهو جزء مهم من الانفلاماتوري process بالgout. من نمنع attraction of neutrophils to the inflamed joint راح نمنع progression of inflammation. بالإضافة, colchicine blocks cell division by binding to mitotic spindles. It also inhibits the synthesis and release of leukotrienes B4 and interleukin-1 beta. Therapeutic uses. The anti-inflammatory activity of colchicine is specific for gout, usually alleviating pain of acute gout within 12 hours. Colchicine must be given within 36 hours of onset of attack to be effective. Well, non-steroidal have largely replaced colchicine in treatment of acute gouty attack for safety reasons because of the adverse effects, common adverse effects caused by colchicine, which are mentioned lately. Colchicine is also used as a prophylactic agent to prevent acute attacks of gout in patients initiating urate-lowering therapy اللي حكينا عليها. Pharmacokinetics. Colchicine is given orally, followed by rapid absorption from GI tract. It is recycled in the bile and excreted unchanged in the feces or urine. Adverse effect: it may cause nausea, vomiting, abdominal pain, and severe diarrhea. Hepatic necrosis, acute renal failure, disseminated intravascular coagulation, and seizures. Chronic administration may lead to myopathy, neutropenia, aplastic anemia, and alopecia. The drug should not be used in pregnancy and should be used with caution in patients with hepatic, renal, or cardiovascular disease. Urate-lowering drugs used for prophylactic or chronic gout. First, allopurinol. Allopurinol is a purine analog. It is a preferred and standard of care therapy for gout during the period between acute episodes. It reduces the production of uric acid and competitively inhibiting the last two steps in uric acid biosynthesis شفناها سابقا that are catalyzed by xanthine oxidase. Uric acid is less water soluble than its precursor. When xanthine oxidase is inhibited, the circulating purine derivatives are xanthine and hypoxanthine, which are more soluble and therefore are less likely to precipitate. لذلك هاي فائده للتريتمنت انه راح تقلل اليوريك اسيد وتزيد لنا الزانثين وهايبوزانثين اللي ما نخاف من عندها because they are less likely to precipitate. In contrast to uricosuric drugs, allopurinol causes a decrease in uric acid excretion and corresponding increase in the excretion of hypoxanthine. It also increases reutilization of hypoxanthine and xanthine for nucleotide and nucleic acid synthesis. The resultant increase in nucleotide concentration leads to increased feedback inhibition of de novo purine synthesis. Therapeutic uses of allopurinol. Allopurinol is effective in the treatment of primary hyperuricemia of gout and hyperuricemia secondary to other conditions such as that associated with certain malignancies, because in malignancy there is production of large amounts of purine, particularly after treatment with chemotherapeutic agents. Allopurinol is ineffective in treatment of acute attacks because it may exacerbate the inflammation. Pharmacokinetics. Allopurinol is completely absorbed after oral administration. The primary metabolite is the active alloxanthine oxypurinol, which is also a xanthine oxidase inhibitor with half-life of 15 to 18 hours. The half-life of allopurinol is 12 hours. لذلك الأكتيف ميتابولايت يشتغل أطول من first track. Thus, effective inhibition of xanthine oxidase can be maintained with once daily dosage. The drug and its active metabolite are excreted in the feces and urine. Adverse effects. Allopurinol is well tolerated by most patients. hypersensitivity reactions, especially skin rashes, are the most common adverse reactions. Acute attacks of gout may occur more frequently during the first several months of therapy. Therefore, colchicine or non-steroidal anti-inflammatory drugs should be given concurrently. Adverse GI effects such as nausea, diarrhea are common. Allopurinol interferes with the metabolism of the anti-cancer agent 6-mercaptopurine and the immunosuppressant azathioprine because these drugs are metabolized by the same xanthine oxidase, requiring the reduction in the dosage of these drugs by about 75%. لذلك من نستخدم هذه الأدوية ويا الألوبيرينول لازم نقلل الدوز مالتهم لأنه راح يقل الميتابوليزم مالتهم بسبب الانهبيشن of xanthine oxidase. Allopurinol is contraindicated in pregnancy because of suspected congenital malformations. Febuxostat is the first non-purine inhibitor of xanthine oxidase. يعني structure مالته مو purine. Pharmacokinetics 80% absorbed following oral administration. Maximum concentration reached after in 1 hour. It is extensively metabolized in the liver, and the drug and its metabolite eliminated in the urine. It is more potent than allopurinol and more selectively inhibits xanthine oxidase. Adverse effect profile is the same as allopurinol, although the risk for rash and hypersensitivity reaction may be reduced. It does not have the same degree of renal elimination as allopurinol and thus require less adjustment in those with reduced renal function. It should be used in caution in patients with history of heart disease or stroke, as this agent may be associated with a greater risk of these events as compared to allopurinol. It has the same drug interaction of allopurinol with 6-mercaptopurine and azathioprine. As with allopurinol, prophylactic treatment with colchicine and non-steroidal anti-inflammatory drugs should be started at the beginning of therapy to avoid gouty flares. Uricosuric agents, propinicid and sulfenpyrazone. The uricosuric agents are weak organic acids that promote renal clearance or excretion of uric acid by inhibiting the urate anion exchanger in the proximal tubule that mediate urate reabsorption. The drugs المهمة هي propinicid and sulfenpyrazone. Lesinurad is a promising new uricosuric agent which inhibits the function of a transporter protein involved in uric acid reabsorption in the kidney. Well, it's a new uricosuric agent and have no wide use. Pharmacodynamics, uricosuric agents, propinicid, sulfenpyrazone, and large doses of aspirin prevent the reabsorption of uric acid from proximal tubules, leading to reduction in the total urate pool. Reduction is associated with decreased tophus deposits of urate and relief of arthritis. Uricosuric therapy should be initiated in gouty under-excretion of uric acid when allopurinol is contraindicated or when tophi are present. Pharmacokinetics, propinicid is completely reabsorbed by the renal tubules and metabolized in the liver, half-life 5 to 8 hours. Sulfenpyrazone or its hydroxylated derivatives is rapidly excreted by the kidney. Adverse effects of these drugs are few. However, sulfenpyrazone inhibits prostaglandin synthesis and shares some of the risks associated with non-steroidal anti-inflammatory drugs, including the potential for causing GI, renal, and hematologic adverse effects. Propinicid may cause nephrotic syndrome. Propinicid blocks the tubular secretion of penicillin, and it is sometimes used to increase levels of the antibiotic in severe infections. It also inhibits excretion of naproxen, ketoprofen, and indomethacin. Well, effect of propionate acid with penicillin is beneficial because of the increase in penicillin level and use it in severe infection. Both drugs increase the formation of renal stones, therefore a large volume of fluid should be taken at least early in the treatment. The urine pH should be kept above 6 by the administration of alkali حتى لا يصير عندنا renal stone during treatment with uricosuric drugs. Last subject is the catabolic enzyme preparations. In animals, uric acid is converted by the enzyme uricase to allantoin, which is very soluble product. يعني بالانيمالز تختلف على الهيومن، عندهم فد enzyme called as uricase يحول لنا اليوريك acid الى allantoin. Allantoin soluble، ماكو مشكله بالانيمالز. Which is freely eliminated by the urine, so animals have very low serum urate levels. طلعوا drug اسمه bigloticase. Bigloticase is a recombinant uricase recently approved for the patients with refractory gouty or chronic gout as an intravenous infusion formulation. It is uricase مثل ما قلنا، فراح يحول لنا اليوريك acid إلى allantoin. Bigloticase has been shown to maintain low serum urate levels for up to 21 days after a single dose at doses of 4 to 12 milligrams, allowing for IV dosing every 2 weeks. It must be administered in the clinic with supportive measures because of the risk of life-threatening allergic reactions. Nephrolithitis, arthralgia, muscle spasm, headache, anemia, and nausea may also occur. فلازم ينطي بالكلينيك with supportive measures لأنه because of the risk of life-threatening allergic reactions. A similar recombinant uricase enzyme, RASP uricase, is indicated only for the initial management of plasma uric acid levels in pediatric and adult patients with leukemia, lymphoma, and solid tumor malignancies who are receiving anti-cancer therapy. It is administration by intravenous route carries the same risk of allergic reactions as bigloticase. Thank you very much for your listening.